I've heard several people say, I think my husband's got Parkinson's. I said, well, did he see a neurologist? And they said, no, I went to Google or I went to my Chat GPT and I asked them based on my husband's tremor in one arm, what could that be? And they said Parkinson's.
While the AI has access to enormous amounts of published material, when researchers publish these things, there's a lot of unspoken stuff that they just assume that other physicians are going to know or are going to understand.
Exactly.
And they're not necessarily spelling that out. So the AI isn't getting that. I saw a recent New York Times editorial where I think AI was being compared to a somewhat rambunctious teenager. Anytime somebody describes symptoms of depression, they have to ask about a history of mania because the criteria for major depression and for bipolar depression are virtually identical. The internist started him on an antidepressant. What he hadn't asked him was whether or not he had this history of mania. And sure enough, he switched into a manic state, got into his car, and started driving across the United States.
Hello and welcome to Health Frontiers with Dr. Bob. I'm Dr. Bob, and I want to welcome all of you to our show today, which is quite interesting. We're going to be talking about a number of things related to mental health and psychiatry. We want to talk about the balance between medication and psychotherapy, the impact of mental health and potential over- and underdiagnosis of personality disorders, and the societal context of mental illness, how it affects our legal system and vice versa. And we're going to be talking about ethical concerns related to genetic testing for mental illness. And we're going to talk about aggression in schools and visibly disturbed kids carrying guns and murdering their fellow classmates and teachers and all of this sort of thing. Explanations and treatments for conditions such as adult ADHD, bipolar disorder, and various anxiety disorders. I'm sure you're all going to find this exquisitely interesting. I want to introduce you to our guest. Dr. Aaron Kulik is our guest today. He's in private practice since 1994 in New York City. He was on the staff of the McLean Hospital in Boston, which is part of Massachusetts General Hospital, the Harvard system. He was a clinical and research fellow there, and he was a Mailman fellow. And those of you in psychiatrists will know what that is. He really was a Mailman fellow in medical psychiatry. He got his medical degree from Wayne State University, and he was a resident and intern at Boston University Hospital. He got his BA, magna cum laude, in biology, which I think is relevant to the biology that we're going to talk about, at Brandeis University. And I want to welcome Dr. Kulik. Welcome to the show.
Thank you. Pleased to be here.
It's a great pleasure to have you. So we're going to jump right into this. In modern psychiatry, do we overdiagnose personality disorders? Everybody, every newspaper headline seems to indicate that the people who are arrested for violent crimes have personality disorders. Are these natural variations in human behavior based on socioeconomic status or where a person works or lives or how they were treated previously? Was it a result of their incarceration? What's your opinion on that, Aaron?
Yeah. Well, I'll tell you, I'm not sure that it's necessarily over-diagnosed. It may be that it's over-referenced by reporters who are speculating, about these individuals that you're alluding to. In actuality, everybody has some of the traits that are listed under virtually every personality disorder. However, in order to meet the criteria to actually carry a diagnosis, first of all, it has to be causing a serious impairment or suffering in the individual and or those around him. So simply having, some of the symptoms is meaningless otherwise. And secondly, they were called cluster diagnoses, meaning that to meet criteria, you can't just have one or two of the characteristics. Typically, you have to have let's say 4 or 5 of them.
Mm-hmm.
And so what starts to happen is if you have 1 or 2 of them, it's usually not that problematic. But if you have 5 or 6 of them, it's a lot.
So most psychiatrists know what these characteristics are.
Correct.
But the legal system doesn't. Not that I'm nailing judges or lawyers to the wall, but I mean the mental incompetence diagnosis is often put forward as an excuse. So we label a lot of people as having mental illness. Do you think that could be a natural response to an irrational world? I mean, people are getting crazier and crazier, it would seem. And should psychiatry address societal dysfunction more? I know they're saying now in New York City they can't put everybody in jail, particularly those who are mentally ill, if they are mentally ill. How do you feel about that?
Yeah. Well, look, I think there has to be a lot more treatment available. And it comes down to economics. It comes down to what the taxpayer is willing to allocate to mental health. So I think the more it filters in that it's a very serious problem. Maybe more money should be allocated to that.
Okay. Let's do a deep dive right into some of the diseases, and then we'll come back to the societal implications.
Yeah.
So what is adult attention deficit and hyperactivity disorder, better known as ADHD for our viewers, and how does it present compared to childhood ADHD? And how do you treat it? Is it as common as we think it is? Because being an interested party in epigenetics as I am, I read often that ADHD and autism are confused a lot. Do you find that to be the case?
Yeah, it can be confused with autism spectrum disorders. It can be confused with learning disabilities sometimes in children. Some of the symptoms of ADHD overlap with other psychiatric diagnoses. Just as a quick example, if somebody is bipolar and having manic episodes, one of the symptoms of a manic episode is distractibility and a decrease in attention. So, but it will be restricted to those episodes of mania. It won't be a chronic condition all of the time as an ADHD. So basically what the psychiatrist or the psychologist who's diagnosing it has to do is they have to tease out these various diagnoses. And to make things a little more complicated, sometimes there's comorbidity. Sometimes a person has more than one thing going on. The other thing with ADHD is to make the diagnosis, the person has to have had ADHD when they were younger than 12.
Really?
It's not a brand new condition.
So that's a prerequisite for the adult diagnosis.
Correct. That's in the DSM-5 criteria. Now, sometimes when I get older patients, they may not have been diagnosed as children because people were not as aware of it. But in taking a careful history, you can elicit that they were having a lot of the symptoms of ADHD as children.
Well, that's pretty interesting. Very interesting, actually. So let me ask you, what is bipolar disorder? We hear a lot about bipolar disorders. And I've heard people who say, I don't get along with that person because he or she is bipolar. Well, that's not a lay diagnosis. How do you define that psychiatrically?
Okay. Well, I mean, in very simple, everyday terms, it's a form of significant and severe mood swings that are, again, causing a lot of distress either to the individual or to his spouse or family, or sometimes society in general. Now, having said that, again, it's a clustered diagnosis. So typically there are, I think, about 8 symptoms of a manic episode. And if the person has the typical very euphoric, very high mood going on for at least a week or more, and simultaneously they're having at least 3 of these other symptoms, such as a decreased need for sleep. Maybe the person's only sleeping 2 or 3 hours a night, racing thoughts,
right?
Often reflected in a very rapid, pressured, lots of volume of speech. They tend to get very impulsive. They do reckless things. They're often grandiose. I had one woman years ago who gave me one of her many cards because she told me she had just started up something like 4 or 5 different companies.
That's pretty interesting.
And sadly, she didn't even have one company. but that was part of the grandiosity. But along with it, she was talking a mile a minute, and she admitted to her thoughts racing, and she needed very little sleep because she had so much energy and was so hyperactive, and she was very euphoric.
So that becomes very, very interesting. And I mean, as a doctor, I can see a lot of that in many of my patients, as I'm sure you see only that. But how is bipolar depression, when they go into depressive states, how is that different from unipolar depression, which is a major depressive disorder? And very concerning.
Well, that's an excellent question. And one of the things that I used to teach the medical students was anytime somebody describes symptoms of depression, that they have to ask about a history of mania. Because the criteria for major depression and for bipolar depression are virtually identical. However, these episodes of depression are not coming by themselves, so it's not like the person either on at least one occasion or perhaps on a episodic basis is having episodes of major depression with no history of a manic episode. Instead, it's almost a modular kind of a thing where some of the episodes will be depressed and some of the episodes will be manic. However, it's treated differently. So in about 30% of the cases, if somebody with bipolar depression, who has this history of mania, is given an antidepressant, about 30% of the time, the antidepressant will switch them into a manic episode.
Oh boy, that can be a big problem.
Yes, it can. I had one colorful example of that years ago, in which this individual was discharged from the armed services, and he became terribly depressed. And the family was particularly concerned because he was expressing suicidal ideation, which is a symptom of major depression. So the internist started him on an antidepressant, but what he hadn't asked him was whether or not he had this history of mania. And sure enough, he switched into a manic state, got into his car, and started driving across the United States. And the family was worried to death. The internist was worried to death, frankly, because of the suicidality he'd been describing. And now they couldn't get hold of him, and he was off and going, and again, in this very hyperactive, impulsive way that a manic person might. Now, fortunately, they were eventually able to locate him somehow, I think through his cell phone, somewhere down in North Carolina.
Thank goodness for cell phones again. They're very, very useful when we really need them.
That's right. And the state troopers down there located him, and he was brought back to New York and referred to me. And at that point, rather than an antidepressant, I put him on a mood stabilizer One of about 4 of them that are FDA approved for treating bipolar depression. This instance, it was Seroquel, and he responded beautifully to it.
Without harming himself. So everything is resolved with him.
Everything resolved, yeah.
Does that therapy have to continue for the duration of his life? As I would think.
Well, I think that's a discussion, between the patient and their doctor. If it's a single episode, conceivably, after I would say at least a year of being stable, one can try cautiously weaning it off. But at the very first sign that symptoms are coming back, it has to go back. If there have been several episodes, or if there's been a life-threatening aspect to an episode, let's say somebody who actually tried to commit suicide during a depressive episode, then you really have to think about taking it as a chronic medicine, much the way a diabetic may take glucophage or insulin.
Yes. Fascinating. So I want to encourage those of you who are viewing us, and perhaps those of you who are listening to us, to try to connect with us and follow our programs. We have many such programs as interesting as this one, both in the future planned and in the past. Our programs are highly regarded, and you can comment on the content as well as follow our shows. Health Frontiers with Dr. Bob. Now, my next question, Dr. Kulik, is the most common anxiety disorders. A lot of patients of mine come in saying, oh, I'm so nervous, and of course, the confusion here is I have patients as a rheumatologist who do not sleep because of severe pain. Now, obviously, it's probably not that difficult to confuse manic depression with an inability to sleep because of pain. But what about anxiety? Everybody, it seems, is on Lexapro or some other anxiety mitigating drug.
Yeah, this is true. I mean, the overall incidence of anxiety disorders, and it has the highest, as a group, it has the highest incidence of any psychiatric disorder, is about 26%.
It's pretty high.
It's very high. Now, the two, probably the most common one is what we term generalized anxiety disorder. And this is similar in a way to this issue with personality disorders, because all of us get anxious sometimes.
Of course.
I got a little anxious before this podcast.
Well, I'm glad that you overcame your anxiety.
Yeah. Well, you're actually very calming.
Well, that is good.
Presence, so.
It's my physician personality.
Okay. So this is why you do what you do.
So do you advocate anxiolytics? For those of you who don't know what that is, that's a drug that breaks the anxiety and makes it more palatable to go on with your day-to-day activities such as work or with your family, etc. So do you agree with the drugs that are being used in copious amounts?
Well, copious is a relative term. It may be that they're overused because as a society, we have a tendency to want to reach for the pill.
Yeah.
And for quick fixes. From a more psychological perspective, sometimes anxiety is a warning sign that you have to change something in your life.
Right.
Okay. But if it is of sufficient severity, getting back to this idea of cluster diagnosis, if somebody is having at least 3 out of 5 symptoms of generalized anxiety, such as excessive worrying, feeling very stressed out and on edge, being very irritable. Sometimes this impacts on family dynamics. Having insomnia because they're too anxious to relax enough to fall asleep.
Wow.
And as I mentioned earlier, a decrease in attention and concentration. Again, they're distracted by all of this excessive worry. So if they're having at least 3 of those 5 symptoms, and it's disrupting their life, and it's
especially with other family members. I can think of my family, the extended family and relatives that we have. Everybody dreads the high anxiety person at Thanksgiving, for example. So
that's correct. And sometimes, a patient will complain that, they're sort of snapping at their children, the wife's upset. So if it's really becoming a problem, there are some very effective medications for it. And in addition, there's some effective cognitive behavioral therapy for it. But the thing that is often necessary, even if they're seeing a cognitive behavioral therapist, is a medication. Now, there are two broad groups of medications. If somebody needs an immediate effect, for example, let's say they're having severe panic attacks, which is the other
very common
anxiety disorder is panic disorder. And there's even a certain incidence of suicide relating to that because the panic can feel unbearable.
Right, a feeling of imminent death. And this happens to both men and women. This is not gender related, although we can talk about gender specific mental issues.
Yeah, that's correct. So if you want something that works immediately, then you reach for one of the benzodiazepine medicines, which are in the same group as Valium.
Yeah,
one that's used a lot is Klonopin or clonazepam. Ativan is used a lot. Now, that may start working within minutes. And what I'll often do with a patient like that is I'll simultaneously, if it's that severe, particularly for panic disorder, I'll give them a small prescription for that. But I will also start them on an antidepressant because all of the antidepressants, like you mentioned, Lexapro, which is an SSRI, serotonin reuptake inhibitor, all of them are terrific anti-anxiety medications, but they can take anywhere from several days to 2-3 weeks to start working.
Wow.
And so meanwhile, the person has the more immediate acting drug available to them. And then if they're getting a good response from a drug like, let's say, Lexapro, then you can taper off or not use the other one because those are potentially habit-forming. They are controlled drugs.
Well, this is very interesting because while we're on the topic of anxiety, as a physician and as other physicians, I'm sure, who are watching us, when does a physician feel that he should bring a psychiatrist into the treatment plan? If the patient's just saying, I have rheumatoid arthritis and I'm so frightened, I can't sleep. And of course, we have to differentiate between sleeplessness with pain and sleeplessness because of anxiety. When does the physician, or when is it prudent for the physician to refer a patient to you as a psychiatrist?
Well, I think certainly if the patient is expressing suicidal thoughts, it has to be referred.
Yes.
The other thing is if the internist is beginning the treatment. And across the United States, most antidepressants are prescribed by family doctors and internists. I actually gave a grand rounds at Beth Israel North shortly after I came to New York, specifically on how to choose an antidepressant for a grand rounds for an audience of specialists in internal medicine.
Well, that's great.
And I was very surprised at how sophisticated a lot of the questions were that I got after the talk. And it was clear to me that all of these guys were prescribing these drugs and even more serious drugs that I wasn't sure they should be prescribing, but nevertheless they were. So the other time to refer would be, let's say the internist starts the patient on something like Lexapro, and it's not working, or they're having a lot of side effects on it. I think once it starts to get more complicated than that, it's good to refer to a psychiatrist who has expertise specifically in psychopharmacology.
And again, if you're watching us and you want to connect with us and comment, and I'll get back to you, I'll reply to your comments, and you can follow Health Frontiers with Dr. Bob on Spotify, Apple, and of course, YouTube, and many others for that matter. The next question, since we're on specific ailments, is obsessive compulsive disorder. Now, I don't know how common that is, but I have a lot of patients who tell me I have OCD. And I have physicians who tell me I have OCD. Now, I look at my office, which is piled high, both at home and in my practice of medicine, which is cluttered with everything. And I'm certainly not a germaphobe, and I'm not a neat person. And I, not that I cherish not being neat. I'm a little disorganized because I am so busy. But there are people who manage to file everything immediately, and on their desks look better than this. There isn't a single object. So I went into one of my colleagues' offices and I said, I have never seen anyone so neat. And the doctor said, I have OCD. What is OCD?
Okay. So first of all, I want to preface it by saying that speaking of personality disorders, in addition to full-blown OCD, there is an obsessive-compulsive personality disorder.
Okay.
And I don't know how you get through medical school and practice medicine without having some aspects of that.
That's true. I agree with that.
The only profession worse is probably accountants.
Accountants. Very good. This is good for tax time. So those of you who are out there who are accountants, you may have an obsessive-compulsive personality. But that's a good accountant, though.
Exactly. You want your accountant to be like that. So an obsessive compulsive personality, and again, we don't give the diagnosis unless they have enough of the symptoms of it, and it's really getting in the way of their life. But typically, that would include symptoms like what you're describing. We don't use CDs anymore. But back in the day, the CDs or the albums would be in exact alphabetical order.
Yes.
And everything had to be put back immediately.
Yes.
And the person might be distressed if you didn't or put it in the wrong spot.
Well, everybody remembers Howard Hughes, who did not touch anything without washing his hands 20 times. And I have patients that do that.
Yeah, well, that I think is more OCD.
Yeah.
So the obsessive-compulsive personality disorder is like the doctor you're referring to, where the desk is immaculate and everything in its place, et cetera. Clothing have to be immaculate.
Yes.
And perfect, et cetera. In OCD is characterized by having either severe obsessions, obsessive thoughts, and or compulsive behaviors. So the Howard Hughes example, for example, his germ phobia and his constantly washing his hands, and I think visitors had to be prepared in a special way also because of his germ phobia.
Maybe wearing gloves when they went to meet him.
Probably gloves and maybe little booties over their shoes, and they couldn't shake hands and probably had to stay a certain distance away. And but this is a compulsive behavior.
Yes.
Some people can't go to sleep without, let's say, walking around the bed 5 times. They have the ritual they have to do. Or they have checking behaviors, like they can't leave the house without making sure it's locked half a dozen times. Or they check back, burners are off. Again, half a dozen or more times. I had a patient with OCD who was a carpenter, and he had to hit every nail exactly 8 times.
Is that right?
And this is a skilled carpenter. He could have done it with 1, at most 2 hits.
Wow.
Okay, but he had to count and had to do it 8 times. He couldn't walk past the fence without feeling compelled to go over to touch it. And there were other things along those lines. Now, if he didn't do that, he would experience a tremendous amount of anxiety and distress. Okay, and then the obsessions are thoughts that they may be what we call egocentric. It may fit in with what the person is worried about, or it may be ego dystonic might be something that a person would never imagine doing. Like I had many years ago when I was at McLean, I had a female patient who had this terrible obsessive thought. She had recently given birth, and she was terrified of these thoughts about dropping the baby. Okay, and it turned out that she was also comorbid with postpartum
depression,
wow. which became psychotic. She had a delusion that the baby had been possessed by Satan, actually, and it wasn't even a safe situation to have her alone with the baby until she was adequately treated.
Wow.
So if the person has these obsessions that, they don't want to have these thoughts, but they keep thinking them over and over and over, and they can't get rid of them, which is a very distressing symptom, and or they have the compulsions. Now, some of them only have one or the other. Others have both the obsessions and the compulsions. It used to be classified as an anxiety disorder, I think in part because these behaviors that I'm describing, like the checking behaviors, seem to bind anxiety. If the person was, in research settings, if the person was stopped from, let's say, washing their hands or doing the behavior, they often would have enormous anxiety.
Extraordinary.
Yeah. And interestingly, the OCD is treated with some of the same drugs that are used to treat anxiety and depression, except we lean into the ones that are, without getting too technical, that are more serotonergic. So there's a bit of a hierarchy of which of those drugs you might begin with and which of those drugs you might then move to.
Right. So for the child, and these are specific cases that I know of, for the child who sleeps in the bathtub, who does not want to sleep in his or her bed because he or she is worried about the environment affecting them. They want to be safe. They have to feel safe, and they wash their hands 15 times a night before they go to bed. They have this ritualism, you say. You're saying that you can treat this, but it has to be a very defined, and I guess the family has to get involved in supporting your therapy. And where does psychotherapy come into this?
Yeah, well, I think psychotherapy comes in the sense that it's trying to help the person deal with the illness, cope with the effects of it. Perhaps looking for other ways to decrease their, anxiety. Maybe they need to have a very set routine, or have a system where everything is indeed kept in its place.
Right.
Things to decrease it. Now, having said that, these days a lot of people will see a separate psychologist or clinical social worker for the psychotherapy. And many psychologists in particular are extensively trained in cognitive behavioral therapy. Now, having said that, because OCD is a very difficult thing to treat, it's not unusual for me to get calls from the separate psychotherapists basically saying, Dr. Kulik, can't you increase the medication?
Yes. Yes. And you say, no, I can't, or yes, I can.
Well, sometimes I can, and sometimes I can't. But what I'm sort of getting at is that ultimately, I think for something as serious and probably biological in origin and genetic in origin as OCD, I think the medications are indispensable.
Yes. So this brings me to biology, and we're going to go into the social aspects of mental illness. But biology, I have a particular interest in epigenetics, which is how the environment affects gene expression. The genes don't change, but the expression changes. And I'm really amazed reading through the literature that a lot of mental illness, which overlaps, as you have said, is really dependent on the environment, and that a lot of these drugs do affect methylation of genes, acetylation of histones, non-coding RNA and all that sort of thing. So that may be the future for treating some of these diseases. A lot of these drugs do affect these kinds of biological mechanisms, which are pretty interesting. This is revolution. AI is going to enter into this in a way that will help things. But we probably could have a special show just on epigenetics and its effects on behavior. Let me ask you, let's go forward and let me ask you, do you think psychiatry has leaned too heavily on medication, since we're talking about that, over psychotherapy in recent years? I was always amazed at psychotherapy. How does it work? What does it do? A lot of my colleagues say really patient autonomy is undermined with psychotherapy, that everyone should see a psychiatrist. How do you feel about that?
Okay. Well, it's a complex question. There's a bit of a history to this because earlier in my career, we were very extensively trained in psychotherapy, and just about every psychiatrist I knew did psychotherapy. And at McLean Hospital, for example, the expectation was that, and these were patients primarily being treated by psychiatrists at that hospital, that every patient who had a serious enough illness to warrant their being hospitalized there needed to be seen in psychotherapy at least 3 to 5 times a week. And I used to move through the campus, depending on the weather.
Right.
It was really adverse weather. We also had a system of tunnels.
Very important.
But we also had these beautiful elm and other trees with remarkable foliage in the fall. And underneath all of these old trees, invariably, there would be a redwood, a small redwood table and 2 Adirondack chairs. And you could see staff psychiatrists sitting with their patients on these beautiful days doing psychotherapy.
Well, that's really
I love that. Now, when I came to New York, at one point I joined the panel. I'm no longer on it, but for a while I was on the panel for the 32BJ Building Service Union. And I asked the question of whether I could do psychotherapy with the patients as well, because that's what I was accustomed to doing. And we considered that the gold standard. And they said to me, well, of course you can. But, if you see the patient for a brief psychopharmacology check-in, let's say even 5 or 10 minutes or however long it is,
right,
we'll pay you $80. But if you want to do 45-minute or more psychotherapy session, then we'll also pay you $80. So most of our psychiatrists don't do it. So there was this economics of it that, increasingly the 2 things started to get separated because the insurance companies as well compensate the psychopharmacology as a medical treatment at a much higher amount for time than they do the psychotherapy. So together with the increasing interest by psychologists and clinical social workers and other mental health counselors in pursuing this market for psychotherapy, it sort of naturally evolved to a point where a lot of psychiatrists don't. Some do, and some psychiatrists really specialize in psychotherapy. There's a renewed interest in psychoanalytic training, for example. Do it, but there's a lot of what we call split therapy going on.
Very interesting.
And again, it's for economic. It's really for economic reasons.
With the rise of direct-to-consumer mental health apps, do you see this as democratizing mental health or trivializing serious psychiatric care?
Well, I think there's a little bit of both.
And I have to tell you that I did a piece for national television on patients who go to Dr. Google. A lot of people and a lot of relatives, and this is dangerous, rely on AI to make the diagnosis. And I'm not just talking about psychiatric diagnosis. I'm talking about diagnoses like lupus erythematosus or fibromyalgia or Parkinson's disease. I've heard several people say, I think my husband's got Parkinson's. I said, well, did he see a neurologist? And they said, no, I went to Google or I went to my Chat GPT and I asked them based on my husband's tremor in one arm, what could that be? And they said Parkinson's. So what do you feel about that? This is really wild stuff.
Yeah, I think it's potentially, it can be very dangerous because, the AI has a lot of limitations, particularly around judgment. And in addition, as one of my own mentors has said, while the AI has access to enormous amounts of published material, he said when researchers publish these things, there is a lot of unspoken stuff that they just assume that other physicians are going to know or are going to understand.
Exactly.
And they're not necessarily spelling that out. So the AI isn't getting that. I saw a recent New York Times editorial where I think AI was being compared to a somewhat rambunctious teenager.
That's pretty good.
And there have been a number of concerns where, based on the formula that the AI is following. For example, there was a case of a young man who expressed his suicidal ideation and plans to the AI, and based on how the AI was programmed, it was very supportive of his plans, and he went on to commit suicide.
Oh, terrible.
And
terrible.
So it lacked the judgment. It just had that instruction, or the way it was programmed is. If you're talking with the patient and they want to do whatever it is, just be very supportive.
Well, this brings up a really hot topic, and that's the fact that young people are following AI characters. Mm-hmm. They'll have a personal character friend who will advise them to take their own lives. And that we've seen that a couple of times now in America. I don't know about the rest of the world, but that brings the AI into the equation, and children who don't have the discernment capabilities are listening to these guides. And if the guy says, well, your schoolwork is terrible, your mother doesn't love you, your aunt thinks you're crazy, and so on and so forth, and then they go and jump off of a bridge. This has happened.
That's right.
How do you feel about that? I mean, that's an extraordinary problem.
I agree. That's what I was alluding to.
Yeah.
No, I don't feel very good about it.
Yeah.
And then the other thing I've encountered, perhaps less dramatically, but potentially very serious. For instance, I had a patient recently who had been doing better, dropped out of treatment, but then at some point she apparently signed up. I've had a few cases like this lately. She signed up with one of these AI-driven online clinics to take over her treatment. And at a certain point, either because her symptoms were becoming more serious or the therapist who was assigned to her, perhaps left the program. They just dropped her at a moment's notice.
Just dropped her?
Just dropped her.
Wow.
They just completely abandoned the treatment.
Oh, boy.
And at that point, because she had seen me several years earlier, she called me and she came back to treatment.
This is extraordinary stuff. I mean, we're wading now into really timely issues. And again, if you're watching us, please follow us on YouTube, Spotify, or Apple. But this is extraordinarily important stuff because it's really cutting edge. It's cutting edge news, and it's very dangerous stuff that we're seeing, particularly for young people, teenagers, adolescents, for example. Let me ask you something. in the era of genetic testing, do you foresee a future where we preemptively treat potential mental illnesses before they manifest? Or is that an ethical minefield?
I think it's an ethical minefield.
Right. Okay. Yes.
Yeah.
I mean, I am not aware of any genetic testing that would give us a diagnosis of schizoaffective disorder or manic depressive psychosis at this time in our history. But with AI and the development of all of these ancillary tools, I get a little bit afraid of the fact that, society is moving ahead of where we as professionals are, and that they are going into different directions to their own peril. How do you feel about that?
Yeah. Well, I think clearly a lot of caution is advised. I also think we're a long way off from genetic tests or other kinds of medical tests, other than as a useful tool sometimes in research. They're not really sufficiently validated to make a diagnosis.
Yes.
And I'm thinking of things like, Alan Schatzberg, for example, who's the chairman at Stanford, but was at McLean for many years.
Of psychiatry.
Yeah. Used to do a kind of study in which he would have and we did this on all the certainly on all the research units. The person would get a steroid, specifically dexamethasone, at about 4 p.m., let's say, and then the next morning they would measure their cortisol level.
Yes.
Now, when you give somebody a steroid, it should suppress the production of steroids in general. So,
endogenous or inner steroids.
Yeah, so exactly. So the dexamethasone should have been suppressing the cortisol the next day.
Yes.
And what would happen is sometimes, particularly in very severe depression, there would be what he called a cortisol escape, meaning it didn't suppress the cortisol like you would expect it to.
Yeah.
But he was also very clear that there were a lot of patients in the study who met the criteria for major depression who didn't have the cortisol escape. So he was very clear it could not be used as a diagnostic tool.
Right.
But what it did do was, in terms of biologically understanding depression, was that certain cases involve the HPA axis, which is
that's the hypothalamic adrenal pituitary axis, for those of you who are not familiar with the HPA.
Correct. And what this implied, as I was saying, was that at least in some cases, he was demonstrating a very clear biological abnormality.
Amazing.
So from a research perspective, that was terrific.
That is terrific.
From a diagnostic perspective,
it doesn't help us.
Not so good.
Well, there's so much that we need to learn in mental health, and that brings me to the next question. This is a favorite of mine. Are judges in courts knowledgeable about mental health, or should we assign or educate specific judges to be well versed in it? Because a lot of these people who we see in our daily newspapers and our press who have committed horrendous crimes are taking the mental health excuse as I'm innocent. And an example comes to mind, and that is the murder of the Reiner family, husband and wife killed by their son, who's schizophrenic, who was not on his medication. And there's a debate, which I don't understand, but there's a debate as to whether he was crazy enough to kill his parents, or was he to be accused and tried as a criminal without consideration of his mental state. And that is the case for many criminals. How do you feel about that?
Look, I think there's a very central legal principle that if a person, by reason of insanity, and insanity is a legal term, by the way, it's not a clinical term. But by reason of insanity, they're unable to distinguish between right and wrong at the time they committed the crime, that they can't be tried for it. Now, in a case like that, they can be committed to a forensic psychiatric hospital. It used to be called these hospitals for the quote-unquote criminally insane.
Yes.
In Massachusetts, it was Bridgewater, et cetera. And what a colleague of mine once commented was that in some ways it was a more serious punishment to be committed to one of these hospitals, because they could then hold the person indefinitely until they felt that they were truly adequately treated to no longer be a threat. And for somebody, let's say, with serious
mental illness,
like schizophrenia, paranoid subtype, which I think is what they're thinking about with the Reiner case, they may never be fully better. And so it may be that had they been sentenced to prison, maybe they would have been sentenced for 10 or 15 years.
I see.
They might be out in even less with good behavior.
So that brings to mind is schizophrenia, which we haven't talked about.
Okay.
Is that an endless diagnosis? Is that something that is incurable? I know we have drugs to treat schizophrenia.
Correct.
But does the patient have to be on those drugs forever?
I would say in the majority of cases, it's a chronic illness, and they generally do have to be on the drugs, generally for a lifetime. Now, they may be considerably better with the drugs and considerably worse without them, to the point where sometimes with patients who keep going off their drugs and who are very seriously disturbed, they'll sometimes be treated with long-acting preparations by injection, what are called depot antipsychotic medicines. And, they may have to have an injection every 3 weeks or once a month in order to, keep them out of trouble. And when we talk, you alluded earlier to some of these, homeless individuals. I think they're called unhoused.
Yes, that's right. So, in the interest of time, that's what I was going to ask next. And what should we do about the obviously mentally deranged individuals who roam our streets, ride our subways, and act very strange? And this has been a problem in the city of New York, and all cities around the country forever. We don't have enough mental health beds for these people. Should we take, or should the city take, a more active role in identifying and treating to prevent to give the public some safety?
Correct. All of the above. I mean, it brings up certain civil rights issues because in some studies, the majority of individuals with serious mental illness are not dangerous. And actually, over the course of my career, even when I was at McLean and I was attached to the psychotic disorders program, not that I didn't treat everything else, but we're talking about a 325-bed psychiatric beds, which is big, and other programs. During the 12 years that I worked there, I think I only had 2 or 3 patients who I would regard as truly dangerous. And they weren't always dangerous to the staff. For example, I had one particularly colorful case when I was in charge of one of the psychotic disorders units, who had been fired from his job. So among other things, he went down there to confront his supervisor and try to wrestle a gun out of the hand of the security person. And then he ran off. And he goes to his car. He has a shotgun in the trunk, gets on the highway. Now, this person had paranoid schizophrenia, and he had a delusion that there were, about 100 different kinds of aliens, and was convinced that one of these aliens killed his cat. So he's now on the highway with a shotgun in his trunk, looking for the person, looking for the alien. And this was before the Men in Black films. This was a long time ago.
Gee.
So he's trying to force this car off the road, which I think is about the time the state troopers caught up with him and arrested him, and he ended up at McLean Hospital,
right,
on my unit of all places. Now, there could have been a serious tragedy, except that at the last minute, as he's forcing this guy off the highway, he realizes that this particular type of alien only travels in pairs. And what might have saved this motorist's life was that he was by himself.
That's pretty amazing.
In the car. But this is an example of a delusion that can be very dangerous.
Yes. Very dangerous. Wow.
And happily, he didn't mistake me or any of the staff, for being,
yes,
aliens like this. But but in that regard, his delusion was causing him to be dangerous.
Very, very interesting. So I'm going to wrap this up with a very, very important and timely question. Mm-hmm. The public is very, very concerned about youngsters and aggression in schools in particular.
Mm-hmm. Yeah.
And this may apply to all mental illness. Should we allow these patients to obtain guns? Now, when we're talking about youngsters, as we just saw, that there have been family members who have been accused of providing weapons to mentally unstable children. Schools are responsible. Parents are responsible. What is psychiatry as a field doing to deal with this sort of problem, which is extraordinarily important?
Yeah. Well, I'm glad you bring that up. I mean, there are a few aspects of it. You're talking about this case in 2014 that just came to trial of Colt Gray.
Yes.
And his father was convicted. And is
convicted and is going to serve time.
Facing years and years in prison. It's at least the second case. There was a case like that in Michigan. Now, the problem here was that his father bought him an AR-style rifle the previous Christmas, and about a year earlier, from what I've read in the papers, he had already been questioned by the police and the sheriff's department because somebody had reported that he was posting very threatening stuff on the internet.
Yes.
And in addition, what came out in the trial was that he had been having rage episodes. He had complained about being bullied at school. He had a poster in his room of another school shooter from a few years earlier, I think Nicholas Cruz.
Yes.
And all of these warnings are ignored. And the mother, bearing in mind the Michigan case, had asked the doctor to lock away the gun.
Yes.
And he downplayed it and didn't. He was allowed to keep it in his room. Now, there was a study some years ago where they estimated that about 4.6 million households in the United States have loaded, unlocked guns.
4.6 million households.
Million. And clearly in this case, the Colt's gun was not locked away. He was in his bedroom. He had full access to it. So you kind of get into this thing where not all of these shooters necessarily have a diagnosable mental illness. We tend to say, oh, well, they must have been crazy.
Yes.
But it seems like a lot of them have either been exposed to physical violence in the home, either against themselves or they've witnessed it. They're often bullied and have a good deal of anger and rage. And then to make things worse, there's a certain fame or notoriety.
Right.
Remember, he has the picture of the other shooter.
Right, yes. And he
so I think you can't really predict it based on a diagnosis, and a lot of these youngsters are not necessarily diagnosable. Now, having said that, I think if the schools had better, and maybe some of them do, had better programs, integrating the security and a mental health team. Most schools have a clinical social worker. Maybe they need to bring in additional mental health counselors. It may be that some of the underlying stressors that then lead to the rage and this kind of explosive behavior, could be more readily identified and picked up. The other thing that I saw, there's a website that's put together by, I think, one of the schools that had this famous shooting down in Florida years ago. And I think it's called Parkland Promise.
Parkland Promise,
yes. And they did a nice job of summarizing about a dozen different psychiatric studies and other studies on this problem. And what they sort of pointed out was that there's almost always some sort of warning that it's going to happen.
Right.
Stuff posted on the internet, stuff that's shared with classmates. I think they were saying that it's almost 100% there are warning signs. And in perhaps maybe 75% of the cases, there were people who knew about it, who it was shared with, but who didn't report it.
Amazing.
Yeah. So I think the answer has more to do with, educating families that the guns have to be unloaded,
controlled.
Right. Ammunition should be stored separately, etc. And that these kind of incidents have to be reported because invariably, the writing's on the wall. There is a warning to it. And for starters, this can be reported to the FBI. They have a threats office that deals with this. Perhaps the relevant school authorities should be cautioned. But this wouldn't have happened if the father hadn't locked the gun up, and apparently the mother asked him to do that.
Oh, yes.
One of the reasons he was convicted.
Yes. I can see the issue, the problem, inflamed by multiple areas of inattention. I think that's the correct term. Inattention.
Correct.
And the young boy is being his trial is coming up shortly.
That's correct.
But school shootings are a problem in this country. It's not just America. It's a problem all over the world. But it is a problem, and you've explained a lot that can be done for this. And I really am run out of time, and I really find this to be the most fascinating discussion. I mean, really is. We could go on for another hour. It is extraordinarily important that people pay attention to mental health and issues like school shootings and the behavior of your children, your spouse, your relatives, and that psychiatry is the way to approach this. And you can ask your doctor, do you know a good psychiatrist that I can refer my great aunt to because she acted out on Thanksgiving Day and threatened the entire family over the turkey? And, stuff like that we make light of, but in fact, these are very, very important things. So on that note, I want to really thank you for appearing today. And I think that we could, as I say, spend another hour, and we may do that in the near future if that's possible. But this has been extraordinary. It's been very enlightening to everybody who's listening or watching this show. And again, follow our program, Health Frontiers with Dr. Bob, and also ask us questions. Talk to us. Let us know what you think of the show. And if you have any specific questions for Dr. Kulik, I can assure you that I can send him the questions and he will be glad to answer your inquiry. Thank you. Thank you, Dr. Kulik, for appearing. And thank you, audience, for watching and paying attention to this very, very important topic. Thank you for joining us on Health Frontiers. I hope today's episode provided valuable insights into your well-being. Remember, this podcast is not a substitute for professional medical advice, but a source of knowledge and guidance. If you have any questions or topics you'd like us to cover, please reach out. Make sure to like, subscribe, and visit our website at www.healthfrontierspod.com. Join us next time as we continue our quest to uncover the latest in health and wellness. Stay healthy and empowered. Until next time, I'm Dr. Bob.